Welcome to the Delirium podcast. We're going to talk about what delirium is, the importance of diagnosing and managing delirium, and how you can use the 4AT screening tool in your area to try and achieve this. Delirium is an acute change in your cognition, which usually comes on over a number of days or hours. Conscious level is altered, either hyperactive, which you will all have seen when people are restless and agitated and are often very active and exploring in the ward. The other type is hypoactive, which is frequently less well recognised as they tend to be quiet, withdrawn and often sleeping a lot. There can also be a mixture of the two. One of the markers of delirium is that it's very fluctuant, and people's relatives and carers and the ward staff will often notice big changes between visits or shifts. Delirium is common in people with cognitive impairment, but it's important to remember that it is not dementia, as often this is what relatives are worried about. Why is it important to know about delirium? No matter where you work in the hospital, you will come across people with delirium. It is incredibly common. 20 to 30% of all people admitted to hospital will have a delirium at some point during their admission. This is even higher in people undergoing surgery, affecting half of all people. It's associated with much longer admissions, higher rates of healthcare associated problems such as falls, fractures, infections and pressure sores. If you have a delirium, you are much more likely to be discharged to a care home. You're also much more likely to die during your admission than those without delirium. A lot of you will have experienced how distressing this can be to the person, their friends and family, and to the staff looking after them. Anyone can develop delirium, but there are certain things that put you at increased risk, such as extremes of age, if you're taking multiple medicines, if you have pre-existing cognitive problems such as dementia, if you're medically unwell, such as with infections or dehydration, or if you've undergone an operation. Up to 85% of people will develop a delirium within the last few weeks of their life. Any sensory deficits, such as poor eyesight and hearing, increase your risk, as well as any change in your environment, such as admission to hospital. As you can see from this list, the majority of people we look after in hospital will have several factors that put them at increased risk of delirium. Delirium can also be caused by loads of precipitants. Very often a UTI is blamed, but this is massively overdiagnosed, which can cause serious harm. UTIs and other infections can cause delirium, but so can dehydration, biochemical problems such as salt imbalances and problems with your kidneys. Pain's a common cause of delirium and one that we often undertreat because we're worried about the side effects of pain-killing medicines. There are loads of medicines that can cause delirium, either by acting directly in the brain or in an indirect way, such as antibiotics causing C. diff or drugs causing kidney failure. Always remember alcohol and drug withdrawal, including drugs prescribed by the GP as well as illicit drugs. Constipation and urinary retention are really common causes of delirium and are easily treatable, so are really important not to miss. Other things such as low oxygen levels and any direct injury to the brain can also cause it. Another important cause is sleep disturbance, which is a massive problem in hospitals. If you have someone who is at risk of delirium, try and make a conscious effort to regulate their sleep-wake cycle and try not to wake them up in the middle of the night to check OBS and such, unless it is absolutely necessary. In young people with fit, healthy brains, delirium is usually caused by a single problem, such as a severe infection or an injury to the brain. In older people, especially those with frailty, it's often caused by lots of little precipitants, so it's important to keep looking for causes and not just stop when you find one. We know there's a big problem with diagnosing delirium, as only 20 to 30% of people are correctly identified, which is a pretty shocking statistic. In order to improve identification, we introduced the 4AT delirium screening tool last summer, which hopefully you all have some experience of by now. The AMT, which was used previously, didn't differentiate between delirium and other causes of cognitive impairment such as dementia, and didn't allow testing of people who were drowsy or unable to answer the questions. NHS Grampian's aim is all people aged over 65 should have a 4AT completed within 24 hours of admission, although ideally much sooner than this. There will be a small but significant group of people under the age of 65 who develop delirium and who the tool will be very useful in, so please use your judgment and use it in these people if you think it's appropriate. The first part of the 4AT is an assessment of the person's alertness. In delirium, people may be abnormally hyperactive or sleepy. If someone is restless and agitated while speaking to you, they should score a 4. If someone is sleeping, they should wake up with speaking to them or a gentle touch on the shoulder. If they do not, this is abnormal and again should be scored a 4. Next is the AMT4. This is a shortened version of the AMT10, which you will mostly be familiar with. This is 4 questions testing orientation, and this is useful for picking up people with other causes of cognitive impairment such as dementia. As you will see, there's a section that says untestable. This means if people are too drowsy or distracted to start, you score them a 2 automatically. Inattention is very frequently a feature of delirium, and the way of testing for this in the 4AT is asking the months of the year backwards. I usually phrase this as, can you tell me the months of the year backwards, so start at December and work your way back to January. If they struggle with this instruction, you can give them a prompt by asking what the month before December is. Again, as you can see, there's also a section here for people who are untestable. Question 4 is assessing whether there has been an acute change in the person's cognition, pointing towards delirium rather than other causes of cognitive impairment, although there are some forms of dementia which can be quite fluctuant. This is often the part of the tool people have most difficulty in completing. It often involves you getting information from another source who knows the person, such as the relatives, friends or carers, nursing staff if they've been in hospital for a while, or the GP letter accompanying the person, and it's about whether they have been more confused than usual. This information should be obtained as soon as possible once the person's admitted. Always remember to seek permission from the person to speak to others. If a person hasn't scored in the earlier parts of the tool and you've got no concerns about their cognition, there's no need to be phoning their wife to check. Once you have completed the 4AT, you will have a score of between 0 and 12. If you have a score of 4 or more, this means delirium is likely. A score of 1 to 3 suggests cognitive impairment, but no evidence of delirium. And a score of 0 means that delirium and significant cognitive impairment are unlikely. Remember though that this is just a screening tool and should be used alongside your own clinical judgment about a person's cognition. People often feel poorly equipped to manage delirium, so Healthcare Improvement Scotland have developed the Time Bundle to try and help. This is a tick box form to check that you've looked for common causes of delirium and treated them appropriately. I look after people with delirium daily, but I'm sure there are triggers I frequently forget to ask about, especially at the end of the day, and this helps to make sure that I am being consistent. It also importantly prompts you to discuss the diagnosis with the person and with their family. As we said earlier, this is often a very stressful and scary time for people and their families, so explaining what is happening and why and letting them know it will hopefully settle is really useful. As well as treating causes of delirium, there are lots of other things you can all do to help settle delirium quicker and relieve distress. Frequently reorientating a person and explaining calmly why they are here is really useful. Remember, just because you know you've met them before doesn't necessarily mean that they remember who you are and what your role is. Having familiar faces around, such as family members, and bringing in familiar items can be very useful, which is why open visiting works very well for people with delirium. Make sure they can see a clock and a calendar. It's often quite anxiety-provoking to allow people with delirium to explore their environment, but allowing them to do so as safely as possible will help settle the delirium more quickly and also prevent complications from immobility. Try to avoid having people attached to drips and catheters if they're not necessary, as again these can make delirium worse and are often a falls hazard in a group of people whose safety awareness may be impaired. Giving sedation can prolong delirium and makes people more likely to develop healthcare-associated problems such as falls. This should be avoided unless they are a risk to themselves or others, or are very distressed, which hasn't settled with the measures on the slide. There's lots of information out there about delirium. There's a delirium pathway available on the DOME intranet page. Healthcare Improvement Scotland have also developed a delirium toolkit, which is incredibly useful and available from the webpage on the slide. There's also a Delirium Learn Pro module that you can access. If you've got any comments about this podcast, or you would like any more help, please contact myself or one of the others in the slide. Thank you very much for listening.